Sorry for the delay, so I have some limited time. So the topic given to me was microvascular Doppler in US, and since this is a mixed audience, I took the liberty of initially thought I'll talk about the common Doppler modes, and then build on to the topic of microvascular Doppler. Some of it may be very fundamental to the radiology colleagues in the audience. My apologies in advance. So the learning objectives in next 20 minutes or so, and I'll rush through, would be to understand the fundamentals of Doppler imaging, the basics of pulse Doppler and color Doppler modes, and then go on to the topic that was assigned to me, which was microvasculature and how we evaluate it with ultrasounds. Principles and pancreatobiliary applications of microvascular Doppler. This is a beautiful modality to look at liver SOLs, but time doesn't permit me to talk on that. So this is how ultrasound is produced. The EUS is actually a marvel of miniaturization. So we have this transabdominal probe, and this is miniaturized to such a degree that we can actually pass it over the end of the endoscope, and now we are imaging from inside out. And below this red covering, you have these array of piezoelectric crystals, and they are cut so fine, the pitches are so fine. Each of this is a piezoelectric crystal that it is actually thinner than the human hair. So that's how delicate and exquisite these instruments are. And each of these piezoelectric crystals work like this. So I will not go into the principles. I don't have the time of the piezoelectric effect and the reverse piezoelectric effect. But it behooves to say that each of these transducer emits the ultrasound and also acts as the receiver. And we'll see how we need to apply this. So when we transmit ultrasound into the tissue and the ultrasound comes back, it carries certain information. And it carries the information in terms of the amplitude of the reflected signal, and it carries information in terms of phase and frequency. When there is a difference in the amplitude of the signals, this is the basis of B mode image formation. The higher the amplitude, the brighter the pixel to which it is assigned. Look at the waves A and B. The amplitude are the same, but the frequency of B is less than A, and the difference in frequency of the returning signals is the basis of formation of Doppler ultrasound. So if an object is moving towards the receiver, the frequency increases and vice versa. So we can know the direction of flow, and with the speed at which the object is moving towards you dictates the degree of Doppler shift, and this is reflected in color by color saturation, and we shall just see this very briefly. So these are the Doppler modes that are now available. We have continuous wave Doppler, which is used by phlebologists, and in obstetrics we will not talk of this. We have pulsed wave Doppler, the color Doppler modes, which include the color Doppler, power Doppler, E flow or H flow, directional power and directional E flow, and microvascular imaging. So I'll see how much we can cover. But then the fundamental is pulse Doppler. So what we are studying is a blood vessel in which RBCs are flowing. And RBCs don't flow in isolation, they flow in clusters, and they act as Rayleigh scatterers. The clusters vary in size. So there are different groups of RBCs, so to say, flowing at different speeds. And the differing RBC velocities will be translated to a range of Doppler frequencies. On the x-axis, we have time. At any particular time interval, there will be a range of Doppler frequency shifts reflecting the range of velocities of RBCs at that particular point in time. So this is reflected on the y-axis. But then there is also a z-axis, because at a particular speed, a bigger cluster of RBCs may be flowing. So this is reflected by the z-axis as the amplitude or the brightness to the pixel assigned. So I'm sorry to rush through, but this is what we are doing. So we can't depict x, y, and z axis on our spectral display. So we convert this 3 dimensions to 2 dimensions. So we are creating Doppler by these 5 to 10 millisecond pixel boxes. So each Doppler is created by 100 to 20 data lines per second, and the x-axis is the time. The y-axis will tell you in which direction the blood is flowing, and also the mean velocity shift. And since this line has a thickness, at each point the brightness will tell you the amplitude of the Doppler shift. I hope I could give you some introduction. What is color and what is power Doppler? Now, in color Doppler, we will sort of give up the third dimension, that is the amplitude, and we will concentrate on the direction and the velocity. So color Doppler will just overlay a color image on a B mode image, and blue is away, red is towards, so it tells you the direction conventionally. This is called the BART scheme. Blue away, red towards, the BART scheme, that is general. And then the speed at which the blood is flowing will be indicated by the saturation of the color to which it is assigned. When we talk of power Doppler, this takes care of only one dimension of the Doppler spectrum. And here we are depicting the amplitude. So this tells us nothing about what direction the blood is flowing or what is the velocity of the blood which is flowing. It only tells you how much at that point the amplitude or the intensity of the returning Doppler signal. Higher the intensity, it's a monochromatic scale, the lighter the shades. The basis of power Doppler. And this is just to show you a case of portal biliopathy, where we have the bile duct is indented by collaterals and in color flow and in power Doppler. So this is just to reiterate the same thing. We can see the direction towards and away from the transducer and the intensity of the flow, and the take home point is that this is much more sensitive, 5 times more sensitive than a color Doppler. And since we are not angle dependent, this will not show you any black gaps. So this is not related to the angle. So for slow flow velocities and for tortuous vessels, we can use power Doppler. We have now advanced to H flow or E flow. This is just more sophisticated power Doppler in higher resolution. The frequency is more, the line density is more, and you can see the resolution is much better. And we are coming very close to imaging the microvasculature, but this still can't image the microvasculature, which is the topic for today. So let's come to what I had to talk to begin with, the imaging of microcirculation with Doppler. So macrocirculation is by the conductance arteries like the aorta, then the resistance arteries, say the celiac or the SMA, and these will branch around 6 to 8 times once they enter any organ like a nutrient arteries, gradually decrease in size and become arterioles. So these arterioles will themselves branch 2 to 5 times, and they constitute the microcirculation, and they vary from 10 to 50 micrometer, are muscle covered or innervated, lead on to metarterioles. And then there are precapillary sphincters, which then lead on to the capillary bed, which do not have muscles, and which then go on to the venules. So all of these constitute this component of the vasculature constitutes the microcirculation, which is the goal of today's imaging and has huge number of applications. Lymphatics also should be counted here. Now, for reference, I give you the size of a RBC, which is 6 to 8 micrometer. And this is a ultrasound bubble, which is 3 to 5 micrometer in size. Now, why is a normal conventional Doppler, the color or power or E flow, unable to resolve the vessels to this level, to the microcirculation? Why can't we see microcirculation with a conventional Doppler? This is the way the Doppler is done, because when the velocity is low, the low frequency blood velocities is overlapping with the clutter or the tissue motion around it. So the challenge here is to separate out the slow flowing blood from the tissue around the vessel, which is also moving because of pulsations and respiration. And once we use a single frequency filter like we use in conventional Doppler, this is frequency defined, so we take an arbitrary low frequency cutoff. We cut off the clutter, but we also cut off the low velocity blood flow. So hence, since we are cutting off in single dimensions, we can't see the low velocities. And classically, the resolution limit of color Doppler is 1 millimeter and flow is 5 centimeter per second, but with the new generations, 300 micrometer we can go down to, and power Doppler is more sensitive. Now, how do we assess the microvasculature? And for these, we can have contrast-based techniques. The highest resolution is with contrast-enhanced ultrasound. We also have something coming up called super resolution ultrasound imaging. This is a beautiful technology, mostly experimental. So the machine can track each individual microbubble, filter out the overlapping signals, follow them a period of time, and hence create a line diagram, so to say, of very fine blood vessels well below the diffraction limit, which is the limit of ultrasound resolution. B mode is available from GE. This is a proprietary system which is 3 times sensitive than color Doppler, and microvascular imaging, which was actually the topic of today. So we'll talk of microvascular. So to give you an idea how we do microvascular imaging, now we want to preserve the low frequency blood flow. So we talk of something called spatiotemporal coherence. What it means is that the 2 adjacent points in tissue will move with coherence, while clusters of RBCs will not move in coherence. So besides the lowering of the frequency cutoff, if we also talk of the coherence of the clutter or coherence of the movement, then we can use a 3-dimensional filter, often a SVD algorithm, to sort of separate out on the basis of spatiotemporal coherence the clutter or the surrounding tissue noise from the low frequency blood flow. And hence we can image as far down or as far low frequency shift as we can, and this is the basis of microvascular Doppler. And so we can look down to 0.1 millimeter or 100 micrometer. We still can't see the capillaries. The velocity is down to 0.1 to 0.2 centimeter per second. What is most beautiful is being shown here, the frame rate. So despite being such high resolution, the frame rate doesn't drop. In fact, we are imaging at more than 50 frames per second. This is because of the something called plane wave imaging or thick beam or fat beam imaging. Again, I don't have time to go into what it means, but the temporal resolution of such a high resolution spatial imaging is also excellent. Now, these are the microvascular Doppler platforms. The earliest was from Toshiba. Now it is called Canon, and now it has been acquired by Olympus. And they marketed by the name of SMI or Super Microvascular Imaging. This has EUS compatibility. We also have microvascular imaging, microvascular flow imaging from GE and Samsung, microflow imaging from Philips, and what we have in our department, detective flow imaging from Fujifilm, previously Hitachi, and we can run the scopes on area tight 50 with it. And this is the machine we have, and this is compatible. This can drive Olympus, Fujifilm, and Pentax. And now recently the Olympus is about to launch this beautiful Applio i800 machine, and this will drive the Olympus systems with super microvascular imaging. Now, very limited, this tabulation is just to show you that there is very limited applications or very few studies on the pancreatic applications. In general, what this study by Miwa from Yokohama shows, that if you have a pancreatic SOL, you can classify it as hypervascular, peritumoral vessels, intratumoral vessels, and spotted vessels, and linear vessels. So we learned that if there is a pancreatic ductal adenocarcinoma, just by turning on the DFI, the lesion hypovascular, peritumoral vessel, and spotty vessels, no vessels going inside it. This is likely to be a pancreatic ductal adenocarcinoma with very high sensitivity and specificity, even without contrast use. This study from Mulki, this is from Marcel's Mark Giovannini group, also showed that the DFI had excellent concordance with contrast US, and all of these 107 retrospective patients were operated. This is a couple of our patients. We see the same thing. These are pancreatic ductal adenocarcinomas, all biopsy proven. So you have hypovascularity demonstrable on DFI modes. This is another patient of chronic pancreatitis. MPD is dilated. We see a tumor. We expect it to be adenocarcinoma. In this setting, it is isoechoic. E-flow doesn't show us much, but it is more round. Elastography doesn't help us. But when we put DFI, we see that this is not showing a peripheral vascularity, spotty vessels. There are vessels inside. This is actually hypervascular. And so the alarm is raised, and then we do a contrast EUS with sonoview, and we see it nicely enhancing. So this is a hypervascular small lesion, and we did a biopsy, and this was neuroendocrine in the setting of chronic pancreatitis. So odd things happen. This is another, just to show you the kind of resolution we have. This is a huge RCC metastasis in pancreas. This is a periampullary tumor, and then we thought that the enhancement was because of the stent change, but when we saw all these vessels, alarm was again raised. We had planned ampulectomy, but we again biopsy turned out to be neuroendocrine. DFI can also be used for tumor margin definition. I'm sorry, I have 5 minutes, so I'll rush through. Cystic lesions, most of these studies have concentrated on IPMN, the intent being to show vascularity in a mural nodule, and hence say it's a mural nodule and not a mucus clot. That is where all the literature is. But we have been using this quite a lot, and we can show you the in serous cyst adenomas, macrocystic enhancement in the septae, and hence neoplastic septae. We also find it extremely useful in neuroendocrine tumors, particularly the cystic type. Even completely cystic will show you vascularity on the outside. Unpublished observations, we do radiofrequency ablation of NETs, EUS guided, and this is on-table assessment. There is no other modality which will tell you on-table success of your radiofrequency ablation of neuroendocrine tumors. DFI does that. Biliary applications, a whole potpourri of applications. In general, a regular vessel, irregular vessel. Regular vessel means benign, irregular vessel means malignant. Sorry for the rush. This is just to show you a couple of our patients. This is ICPN, intracholecystic.
Take your time.
No,
we have
I won't
few
hold.
minutes.
No, you can
Just explain this.
I'll finish it. So this is a large polypod tumor, looks like sludge, but you can see vessels going inside. This is a ICPN, intracholecystic papillary neoplasm. Again, what it tells you that in practice it is very difficult to define it completely. This patient we sent as benign, but then it had focal area of adenocarcinoma on resection. Was resected here in ILBS. The best application for this is to decide whether this is a tumefactive sludge or something is growing on the gallbladder wall. So again, silence on DFI on the lesion in the wall, and silence on no enhancement on the contrast. So good concordance. But point is, all is not well. Another 47-year-old lady, this is a gallbladder fundal lesion. Difficult to characterize, looks like adenomyosis, but then the outline is a bit irregular, which can happen. E-flow, no vascularity. We put a DFI. DFI is also silent, so we think, well, this looks like adenomyomatosis, no vascularity, but we still did a sonoview. And with a contrast, you see the whole thing is lighting up beautifully. So this is not adenomyomatosis, and just to show you that DFI is a relatively new technology, and we have to be very cautious and still do multimodal imaging. We then went and hit a lymph node, which I would have otherwise not, and turned out to be adenocarcinoma, and surgery proven then subsequently. The limitations are that this modality has been tried on different scopes. These are Olympus scopes, these are Pentax scopes, which have been used in France by Mulki, and this is EG740 UT. We use the Fujifilm platform with this. So the transmission frequency, the dynamic range, the color gain, the wall motion, sensitivity, line density, there are so many parameters that are operator based as they should be, so difficult to compare the sensitivity and other parameters between studies and between platforms. Other limitations are the depth dependency. We can't do very good DFI beyond 4 centimeter. Angle dependency, since this is Doppler based, so it is angle dependent, very susceptible to motion artifacts. So in areas where the signal to noise ratio is low, it sort of falters. Also cannot distinguish arteries from veins. It will just show you a tubular structure with flow through it. It cannot display the phase variation of perfusion like contrast enhanced ultrasound. So CUS will show you the flow in and washout kinetics. And well, I showed you a bit rapidly that the centers which are reporting on this are still very clustered. the Marseille Center, Yokohama, and the Wakayama. These are the 3 centers which have so far published on this. There are certain advantages also over IV contrast. There is no IV contrast required, number 1. 2, it is very easy. You just have to switch a button and the DFI is on. There is no time limitation. A contrast washes out completely within, we use SonoView within 3 minutes, but here you can play on for as long as you like. With contrast, you are still, here you can actually move over an organ with DFI, so you are not restricted to one plane or time. This is another case, looks malignant. It's blue on elastography, hard, less stain. This movie has gone off. We did a contrast, was very confusing. But what we are now coming down and what we are learning is we can do a DFI after contrast. And I was talking to my Japanese colleagues. This is a beautiful modality. DFI is also low MI, and we do a contrast study. Some contrast still remains, and then we again do a DFI, and it shows you beautifully. So this was an inflammatory mass, biopsy proven. My last slide. Finally, DFI is a new modality, and it has to be considered what is called an imaging biomarker. And Cuba guidelines, quality initiating in radiology, and ESR, European Society of Radiology statements tell you how a imaging biomarker should be evaluated. So image acquisition, I was talking of protocols, methodology. We have to work on phantoms. We have to go back and look at pathology, short-term clinical endpoints, long-term clinical endpoints before we can use DFI more widely. So, sorry, the take-home points, I'm still in time, is that EUS microvascular imaging is more sensitive for vessel detection than EUS E-flow, which till now was the most sensitive modality. It can probably resolve vessels less than 100 to 200 micrometer with slow flow. This is microvasculature without contrast injection. How do we interpret it? We refer to the arterial phase CEUS as reference for comparison in studies, but we are still learning this. Real-time, prolonged, multi-lesion evaluation is possible, and this is one advantage over contrast. EUS microvascular imaging can demonstrate lesion vascularization, distribution, and morphology, and this can narrow the differential. Obviously, this has extensive application in liver SOL characterization, and we need significant research to standardize the protocols. Thank you.